there are a lot of barriers that stand between the patient-physician relationship. And that, what was once a sacred relationship, has deteriorated, frankly.
I'm Jeremy Hobson, and this is the follow-up, our weekly podcast that you can only get here on the Middle Podcast feed. And if you are a regular listener and you love listening to The Middle, please share it with a friend. Write us a review on Spotify or Apple or wherever you listen to the podcast. We are following up today on our show about whether or not your healthcare is working for you. And surprise, surprise, it is not working for many people that listen to The Middle, especially because earlier this year, Congress allowed some subsidies for Obamacare plans to expire, which skyrocketed insurance premiums for millions of Americans. And even Americans who do have private insurance, and it's about 60% of the non-elderly population in this country have it through their employer, they've seen their premiums go up too. So with that in mind, we're going to get into more of your thoughts on this as we welcome our guest, Daniel Grossman, an emergency medicine physician at the Mayo Clinic in Rochester, Minnesota. Daniel, it is great to have you here.
Pleasure to be here. Thanks for having me.
Well, and as an actual doctor, have you noticed anything different since the subsidies expired for Obamacare at the beginning of this year?
I don't know if we're seeing a specific subsidy-related impact, but we are seeing more and more patients delaying things, delaying medications, delaying procedures, just working hard to stave off costs. They don't tell us in the ER that it's subsidy related.
But they are delaying things. Does that mean more people are showing up in the ER because they're not going to their primary care physician to deal with things that maybe they would have if their insurance were better?
Or because they can't get their medication refill, they stretch their medications a little bit longer. They've maybe missed a dose, they lost insurance and can't refill their medications. These things are happening with greater frequency.
How much do you as a doctor have to think how your patients are paying for the care that they receive?
You know, in the emergency department, we operate under something called the Emergency Medical Treatment and Active Labor Act, the EMTALA Act. And that, when a patient shows up, our job is to give them a medical screening evaluation and treat whatever the life-threatening condition is. So by and large, we're not taking a financial first approach, but somewhere during the patient's journey with us, you start to see signs of something. Do we really need to do that test? Could we do a different test instead? Could I follow up later? Could we avoid being hospitalized because it's so expensive? So the initial interaction with a patient isn't going to have a financial lens on it, but during the course of that journey, you start to see it come out.
What about the gripes that people have? And we heard so many of them from our listeners about the system overall. Do they take that out on you as a medical professional, even if you may have absolutely nothing to do with some of the problems that they have with the healthcare system?
I think so. And you know, it may be that they didn't get into their primary care doctor, or they couldn't get into their primary care doctor, or their primary care doctor didn't respond. Some people have lost access to their care system that they would have been in before. Or maybe they're fed up with what's been going on at their local facility and they've kind of made their trek to Mayo Clinic. But the gripes of the healthcare system, they show up for patients every day. And when we see patients, it's the worst moment of their life, or sort of they're at their wit's end. But they got there somehow, right? Like something happened along the way.
Well, let's listen to one of our callers, one person that left a voicemail. Not surprisingly, we heard from healthcare providers like yourself. Listen to this.
Hi, this is James Chappell in Denver, Colorado. I'm an active medical practitioner. I am also on Medicare, and I have TRICARE as a secondary because I'm retired military. And for me, the insurance is working well, but as a practitioner, it is not. I am a fee-for-service provider, meaning I do not take any insurances at all because I've had insurances delay payment on me for up to a year. And the biggest problem I have with insurance is they won't pay for the treatments that are best for the patient determined by the physician. They deny it, and I have to appeal it, and, it just takes far too much time. And at some point, the physicians just give up, so patients don't get the care they need because they don't have the time to jump through all the hoops that the insurance companies require.
Daniel, what do you think when you hear that?
Yeah, Mr. Chappell is spot on. There are a lot of barriers and an increasing number of barriers that stand between the patient and as he described it, a medical practitioner, or in our world, the patient-physician relationship. And that, what was once a sacred relationship, has deteriorated, frankly, because of all of the other competing factors that our healthcare system sort of injects into that relationship. So he's not wrong. And, I don't believe that it's purposeful to get physicians or practitioners to stop trying, but that might be the result.
One of the things that our listeners cannot see is that you yourself are in a wheelchair after a spinal cord injury that you suffered in a bike accident many years ago. You and I have talked about this on the air before. You had to deal with the system from the point of view of a patient. Was insurance and payment on your mind as you were going through that at all?
100% of the time. All the time, it was, how am I going to get this? Is it going to be covered? If it's not covered, how do I appeal? And I had both the benefit of good insurance and of understanding the system. And then I spent a little bit of time working at a startup health insurance company, so I had even more experience. So I had a tool set and privilege at my disposal to help navigate that. But it's the first thing you think about. Can I get a new wheelchair? Is insurance going to cover it? My doctor wants to put me on a new medicine. That's not covered. How are we going to solve that problem? Every day.
Yeah. I actually said on the show the other day, and I feel bad that I said it because it is a live show, and I sometimes, I didn't think through exactly what I was about to say, but somebody got mad at me, which is I said, I've had to deal with things with insurance companies and, calling and trying to figure this out and that out. And I said, I'm glad I'm not a senior citizen because I don't know how I would be able to do this if I were. It's very complicated. And again, nothing against senior citizens, but you know what I mean? It's very if my grandparents were having to deal with the kind of stuff I had to do, calling this person and that person, and nobody knows what the other person is doing, it's complicated.
It's terrible. And when I was first injured, I also had I hit my head with a helmet on. I had a traumatic brain injury. My mom filled out all of my paperwork. How do you manage all of these things, and how do you manage them without resources? It's not a senior citizen thing. It's just a terrible, terrible process that people have to go through to try to solve this.
Yeah. All right. Well, let's listen to another perspective. Listen to this caller.
Hi, my name is Skyla, and I'm calling from Massachusetts. And no, I don't think my healthcare is working for me. People used to talk about death panels, and that's why we can't have universal health care, because that would mean bureaucrats are making decisions about our care. We already have bureaucrats making decisions about our health care. I have to go for my annual checkup, and my blood work will not be covered by the ACA's provision for preventive care because my doctor chooses to do blood work that is different from the quote-unquote preventive care designated by my insurance provider. So we already have insurance controlling things.
So a point that came up a couple of times in the show, she sort of gets to the idea of universal health care as an alternative, which is what most of the rest of the world's developed countries have. Why do you think that this country is so allergic to the idea of universal healthcare? Because I remember back in 2010, when Obama passed the Affordable Care Act, he had a filibuster-proof majority in the U.S. Senate, and he still couldn't get a public option into the bill.
I mean, the cynical side of me says that there's a lot of money in the system that is designed to prevent us from moving away from the profit engines that exist around us. That's the cynical side of me, right? The less cynical side is that our society doesn't sort of come together around the mean in a way that is probably required for universal health care and universal health coverage. The outliers that people want to be, like this caller, she likes that her doctor orders tests that aren't sort of approved by the preventative task force. But the reality is that the preventative task force has studied all of the data and has determined what is in the best interest of the vast majority of the people. And so if you're going to have universal healthcare, then you have to be okay with the outlier strategies not being included in that. And I don't think that that's really the American way right now.
You're also at the Mayo Clinic, which is a place where people go when they have like very serious problems, cancer and stuff like that, to get the best possible care. And one of the arguments that often comes up about our system is that it has the tools that maybe other countries don't because of its private style.
Yeah, not just private style, but innovation engine around healthcare, ability to find drugs that might not otherwise be available, or do tests that require an infrastructure that isn't available other places. And we are living in a time where we can discover and identify disease that we couldn't discover 2, 3, 5, 15 years ago. And that's pretty amazing. And yes, that happens at Mayo Clinic, but it also happens around the country where the more tools that are available are leading to more diagnoses and more treatments and cures.
All right, we'll stand by because we've got more of the follow-up with Daniel Grossman, emergency room physician at the Mayo Clinic in Rochester, Minnesota. We'll be right back. Welcome back to the follow-up. I'm Jeremy Hobson. I'm joined by Daniel Grossman, an emergency medicine physician at the Mayo Clinic in Rochester, Minnesota. And Daniel, something that came up over and over was a lot of people are just completely uninsured due to the cost. Listen to this.
Hi, my name is Jacob from Houston, Texas. I don't have health insurance. I haven't paid for it in about a year. It just doesn't seem like a realistic cost to pay anymore. I think we're all asking the wrong questions. All of our people in Congress are arguing about whether or not we should have the subsidies in place. But I think we need to be asking, why is the insurance so expensive in the first place? People are working to pay bills, and it's just not realistic for the insurance to be so expensive.
Daniel, what do you say to Jacob there? Why, or do you have an answer? Why do you think insurance is so expensive in this country?
Healthcare is expensive in this country. And if healthcare delivery is going to be expensive in this country, then the infrastructure required to pay for it and to do reimbursement is expensive. And we can make healthcare less expensive in this country. And it will, in my opinion, lead to longer lines for things, less availability of tests and testing, fewer new medicines or fewer medications being available to people. Our healthcare will change. The healthcare we deliver today is really expensive. And listen, it's terrible that he is uninsured, right? Like that is a choice that he is being forced to make. And he also has access to healthcare in emergency departments or in other places. And it ends up being really expensive for him once he receives that healthcare. And he may be making choices to delay care or not take his medication that we've been talking about before that will then have long-term ramifications for him. And it's a really hard decision people are making.
Yeah, and I wonder how it plays out when somebody comes in to the ER and they're uninsured. How does that play out from your perspective?
Well, if they have a life-threatening condition, and even if they don't have a life-threatening condition, it doesn't matter. We don't know their insurance status or even which insurance, if they have insurance, before we provide them care. That is not on my radar as I'm entering the treatment room and establishing a relationship with them and their family members if they've come with them. No idea what their insurance status is, just that we're there to care for them.
So as somebody who has been in the healthcare industry for so long, do you look and say, this is the one thing I would change? Or like, do you see the biggest flaw and how would you fix it?
We are really, as physicians, I would say at our wits' end. And this idea that there are prior authorizations, which are useful, by the way, but that there are so many barriers to that long-term physician-patient relationship, I would really try to fix that. And we're going to introduce new tools, right? Like AI is coming to the bedside. AI is at the bedside. We use it every day. Many, many places do. PBMs, insurance companies, pharmacies, the relationship has just changed in such a way that we probably won't go back to that personal relationship that existed before. Patients see many, many, many different clinicians when they have an established primary care doctor in a lot of cases. And so we miss the longitudinal nature of that relationship. If that came back, that would be really beneficial to, I think, both the clinician community and the patient community.
All right, let's listen to one more caller here.
Hi, my name is Chris, and I'm calling from Philadelphia. My health care works for me because my husband works and we have private insurance. I have a son who's an independent contractor, and he has a great deal of trouble dealing with health insurance because he doesn't have access to anything other than the Affordable Care Act insurance. And the premiums have gone up to the point where they're skyrocketing. Healthcare is something that absolutely everybody will need at some point in their life. So it should be available and it should cover everybody. It should not be related to your work. That's really kind of silly to do that because then people end up having to stay in a job because they don't want to lose their health insurance. It should be a given for everybody to have access to quality health care.
I mean, that was the whole idea of the Affordable Care Act, was that it doesn't have to do with your work.
Those are phenomenal points. All of those points, right? I have private insurance because it's tied to my employer. People can't change jobs. People don't change jobs. Entrepreneurship is negatively impacted, as you guys talked about on the original podcast. Like this is the dilemma that exists today. And if you're an independent contractor, we should be figuring out a way to reward you for what you're doing, or small businesses. And it is, I don't have the data here at all. It has to be stymieing innovation in some way in this country that health insurance is tied to the larger employer market.
Do you hear from a lot of people who are very satisfied with their healthcare?
No, I mean, we see patients who get access to care and can come and get tests that they might not otherwise get. And many of those are on private insurance because they have access to it, or their employer will support them coming to Mayo Clinic. Most patients are frustrated with some aspect of their care, whether it's the insurance part of it, or that they don't get to see their primary care doctor that often and they see someone else, or that they only communicate with their care team through a portal now. These are, the number of insults that people go through to access the healthcare environment is just growing and growing.
Right. Although when you do have an experience where your healthcare really does work for you, it's such a personal thing that you really are like, wow, okay, that worked out very well. I'm glad I had that doctor that was able to help me in that way. Or now when I meet people that, or I know people that get diagnosed with cancer or something like that, I'm like, well, at least right now you're living in a situation where the advancements are happening so fast, and there's a good chance you're going to be just fine at the end of this.
I think that's right. Whether there's a chance that you're going to be just fine, you're going to have access to testing and medications that people didn't have access to before, and it's going to improve your likelihood of survival. And the healthcare system has safety nets built into it that exist that might not have existed before. And so we are able to provide care to people that they couldn't get before. And that's something to celebrate at the same time as, commenting on the negative aspects to it. We are really, really, we really benefit as a society from innovation that's gone into healthcare delivery over the last years.
Daniel, last time we had you on the show, we talked just a little bit about GLP-1s. How has that affected your life these days with patients? I mean, are more and more people on them? Is it affecting people's health in general?
Yeah, more and more people are on them. People are becoming healthier because of them. They lose weight, diabetes goes away, all kinds of conditions that we're just learning about benefit from GLP-1s. And initially when they came out, people were hesitant to talk about them. Now, lots of people just talk about this miracle drug that's happened and that they experienced and that it benefited their life. And I think that has also helped the uptake of them. In addition to the fact that, we've moved, in addition to the injectables, there are now pill forms of them, which makes it easier and easier for patients to have access to it. We are just on the cutting edge of understanding what these medications and follow-on medications are going to be able to do. And this is the miracle of science. It's pretty awesome.
I had to ask you about that because I feel like it is just like the biggest thing in healthcare right now is the GLP-1s. Okay, everybody that comes on this podcast gets to make a prediction, which you get to, although I'm giving you an option B, which is if you would prefer, because you and I went to high school together at Uni High in Champaign-Urbana, Illinois. If you would prefer to tell the listeners something about me that's not too embarrassing, that would be fine too. Or you can make a prediction.
We actually grew up like 2 blocks from each other. We'd hang out at each other's houses. So I can rack my brain for that or find an embarrassing prom photo of both of us. I'll give you a sports prediction here as we enter World Cup season. I was lucky enough to grow up in the Netherlands off and on, as you know, and I am a Netherlands Holland fan all the way. So I got the KNVB, the Dutch soccer team, winning the World Cup.
Okay, and you can't make a prediction about the Fighting Illini because they just lost in the Final Four.
Yeah, and that would have just been on the nose. Yep.
All right, Daniel Grossman, emergency medicine physician at the Mayo Clinic in Rochester, Minnesota. Great to have you on the show. Thank you.
My pleasure.
And thanks for listening to The Follow-Up. It was produced by Harrison Patino. Don't forget to subscribe to us on Substack. It's listentothemiddle.substack.com. I'm Jeremy Hobson. I will talk to you soon.